Aneurysms. Intracranial aneurysms are classified as saccular, that is berry, mycotic, arteriosclerotic, traumatic, dissecting, and neoplastic. Clinical presentations include cranial nerve palsies, especially of nerve 3, including the pupil and nerves 4 and 6. Headache, mass lesion or steal phenomena effect, that is giant aneurysms, and thrombosis, atherosclerotic aneurysms. Rupture with subarachnoid hemorrhage, SAH, is the primary manifestation. Ruptured saccular aneurysms account for 80% of non-traumatic SAH, most common after the age of 20. A severe headache of sudden onset is characteristic. The size and location of the bleed and the presence of the intraparenchymal and ventricular extension associated with significantly higher mortality affect the level of consciousness, lethargy to coma. Sudden loss of consciousness is the presenting feature in 20% of the cases. Meningeal signs, papilledema, retinal hemorrhage, and seizures are common. Focal signs in the first 24 hours usually indicate parenchymal dissection, cerebral edema, or hypoperfusion distal to the ruptured aneurysm. After the first 48 to 72 hours, focal signs may be due to vasospasm. Diagnostic evaluation includes CT. Results are negative in approximately 15% of cases. And LP if CT finding is negative. Angiography may be possible to locate and define the cause of the SAH, that is an aneurysm or AVM, and should be repeated in 5 to 15 days if results are initially negative. Magnetic resonance angiography is a promising alternative to conventional angiography. The Hunt-Hess grading scale is commonly used for prognosis and timing of aneurysm surgery. Level 0, unruptured aneurysm, symptomatic or incidental discovery. Level number 1, asymptomatic rupture or minimal headache and nuchal rigidity. 1A, no acute meningeal or brain reaction, but fixed neurologic deficit. 2, moderate to severe headache, nuchal rigidity, no neurologic deficit other than cranial nerve palsy. 3, drowsiness, confusion, or mild focal neurologic deficit. 4, stupor, moderate to severe hemiparesis, possible early decebrate rigidity and vegetative disturbances. And 5, deep coma, decebrate rigidity, moribund appearance. Complications and sequelae of SAH result from systemic dysfunction, GI bleeding, respiratory depression, cardiac arrest, cardiac arrhythmias, diabetes insipidus, pulmonary embolism. Cerebral ischemia or infarction is frequent in the first 4 to 14 days after the initial bleed because of arterial vasospasm. The amount of subarachnoid blood correlates positively with the rate of occurrence of vasospasm. The use of calcium channel blockers like nimodipine seems to reduce the occurrence of severe neurologic complications, that is death, coma, and permanent major motor deficits. The use of other agents such as aminophylline, dopamine, and isoproterenol remains controversial. Lysis of the clot surrounding the aneurysm after the initial bleed results in rebleeding, which may become evident as apnea, development of new focal signs, or worsened clinical status. Slightly more than 20% of patients rebleed in the first 2 weeks. More than 30% rebleed in the first month. The mortality rate with rebleeding is over 40%, higher with the initial bleeding. After the first 6 months, the annual rebleeding rate is about 5%, with an annual mortality rate of 1 to 3%. Treating hypertension and maintaining the blood pressure in the normal range helps prevent rebleeding. In the acute phase, induced hypotension is associated with significant ischemic complications and should be avoided. The common sites for aneurysms in the brain are as follows: the anterior cerebral artery and anterior communicating artery, the middle cerebral artery, the junction of the internal carotid artery, the anterior choroidal artery, posterior communicating artery, and the vertebral basilar system. And those are aneurysms. Have a great day.